In this video, we will demonstrate a Hughes-Periosteal-Monopedicle Flap technique for eyelid reconstruction. Sebaceous gland carcinoma is often missed initially as it can act as a masquerade in the form of recurrent chalazions or diffuse blepharoconjunctivitis. After the diagnosis is confirmed, a wide local excision is performed taking 3 mm margins along with the aid of frozen section. Stay suture is applied to the eyelid margin to delineate the tumor. After a stay suture is applied at the medial and lateral end, clean cuts are taken either with the help of a scalpel, scissor or a monopolar cautery to perform stage 1 of the procedure. You may encounter a little bit of bleeding when you cut the marginal arcade. Differential excision can be performed depending on the amount of skin versus the conjunctival involvement. Using the no-touch technique, the whole tumor containing tissue is excised in a block. Once the excision is complete, the margins are oriented and sent for intraoperative frozen section. This is the defect, as we can see, involving the half of the lower lateral eyelid margin along with the canthus. A double freeze thaw cryotherapy is then performed to avoid recurrence of the tumor. Following this, reconstruction or the second part of the surgery begins. In this video, we are going to harvest a lateral periosteal flap, which is being marked here, to fix the lower eyelid and form the lateral canthus. An incision is made on the periorbita, taking care to hinge the flap at the orbital rim. Once the flap is designed, it is then gently peeled off of the bone and is then kept aside. Upper eyelid is everted on a Demers retractor and keeping 4 mm of the upper tarsal border intact. An incision is made and then the tarsoconjunctival flap is harvested. Relaxing incisions are made laterally and dissection is done very meticulously to maintain the vascularity of the flap. Here you can see the edge of the levator muscle within this flap. These are the relaxing incisions made to get more mobility for the flap. Once complete dissection is performed, the flap should stay in its position and not retract back. This is how the flap should look once it has been harvested completely. Hinge sutures are then taken with the help of 6-0 polypropylene sutures, and then the lateral edges of the flap are then secured to the remnant of the eyelid margin inferiorly. The position of these sutures is very important when we divide this flap. These sutures are taken in a partial thickness manner to avoid abrasion on the cornea. Similarly, this flap is then sutured to the inferior fornicial conjunctiva so that it is secure in place. Once the tarsoconjunctival flap sets in position, it's time to turn focus towards reconstructing the anterior lamella. Anterior lamella can be reconstructed by performing a skin graft or a local flap. In this case, we decided to go ahead with a monopedicle flap from the upper eyelid as there was some amount of excess skin. A monopedicle flap is fashioned with the apex being narrow and the base being broad to maintain good vascularity. The monopedicle flap is harvested with the help of a scalpel and is raised and transposed to the lower eyelid. This is how a monopedicle flap looks. It is purposely kept longer so that the end of the apex can be used as a skin graft to fill up the defect, if any. Once the monopedicle flap is secured into place, the apex is then cut off and then sutured separately as a skin graft inferiorly. At the end of surgery, we do give some linear slits in the skin graft to prevent hematoma formation. The flap bed is then sutured with the help of monofilament polypropylene sutures. This was a depiction of stage 1 of Hughes-Periosteal-Monopedicle Flap technique. Thank you.